Now you see this X-ray carefully. See this head? See this head. And compare this head with this head. You find that this head is fragmented, it is shrunken, the joint is not congruous, and there is sclerosis. You can see this sclerosis here. And this growth plate is not smooth. There's evidence that vessels are trying to grow. These vessels are trying to grow through this growth plate into the head. So this head is avascular. And this suggests Perthes disease. This suggests Perthes disease. Now, this child must have presented with pain and limp in the gait, and this could have been unilateral or bilateral. This gait is called as antalgic. So when he bears weight on this limb, the swing phase of the opposite side hurries to take off the weight to avoid pain. So the swing phase of the opposite side is reduced in length, duration, and height. Rotations are painful and restricted. The patient will later develop a flexion, adduction, external rotation deformity, and in the long run may develop osteoarthritis by the age of 30 to 40. So with this, there is what is called as hinged abduction. Abduction is limited, and this limit becomes absent when you flex the hip. So this is called as hinged abduction. The diagnosis is Perthes disease, and in this you have to understand the blood supply of hip and how it is compromised, and then what happens. So you see the blood supply of hip is by the femoral artery and the obturator artery. The obturator artery gives a branch which is the artery of the ligamentum teres, which enters between the transverse acetabular ligament and the acetabulum through the acetabular notch, goes along the ligamentum teres and supplies 3% of the hip. The nutrient artery coming from the shaft goes up to the neck, but it is stopped at the level of the growth plate. The femoral artery embraces the upper end of femur by the medial and the lateral circumflex femoral artery. These arteries give ascending branches which embrace the base of the neck of femur. Now you see that the synovium starts from the acetabulum, comes across the neck and ends at the growth plate. This synovium contains fluid. And when there is synovial effusion, that means there is a lot of fluid in the synovial cavity, and this is within a very rigid capsule, then the synovial pressure would increase and would obliterate the extra osseous vessels that are able to cross the growth plate. The nutrient artery will never reach the growth plate. So the extra osseous vessels are from the ascending branches. They are called as lateral epiphyseal vessels, and since they raise folds of synovium, they are also called as retinacular vessels. So, temporarily, the blood supply of this head is impeded because of tamponade effect of synovial effusion. Now you see here, this is the bone. These are the anterior and posterior retinacular vessels. This is the posterior one, this is the anterior one. They have raised folds in the synovium, so they are also called as retinacular vessels. And this ligament that they form is called as the ligament of Wheat-Brecht. Sometimes you are asked this name. So the artery of ligamentum teres will be coming from here, parallel to this ligamentum teres. And this is, since this is also extrasynovial, these vessels, retinacular vessels, crossing the growth plate and reaching the head, and the artery of ligamentum teres would be pressed and compromised, and this head will become temporarily avascular. So you have synovial effusion, intrasynovial pressure increases, exceeds the arterial pressure, there is tamponade effect, and the osseous arteries are blocked. The intraosseous cannot reach the head because of the growth plate, and the head of the femur becomes temporarily avascular. Temporarily means up to 2 years. Because of this, calcium cannot be removed from the head, from the nucleus of the head. Therefore, it becomes more radiodense. Then vessels try to impregnate this, trying to compensate for avascularity. Therefore, you can see a head which has lots of fragments because of these blood vessels. So it fragments, it stops growing, therefore it shrinks. If this is the head of this affected side, then on the opposite side, this will be the size of the head. And then it becomes surrounded by new bone. So this is called as the head in head sign. So now in this soft stage, if there is weight bearing on the softened head, till it revascularizes, then it is going to tilt downwards. This is the normal shape, and this will become its downward tilted stage. The neck shaft angle would reduce, and there will be an adduction deformity. It will also tilt backwards. You're looking at the trochanter, the neck, and the head from above. It will also tilt backwards, leading to an external rotation deformity. The third thing that can happen is that if this is the acetabulum, then this head, part of the head is outside the acetabulum, and this is the remaining part of the head. So there is hinging at the acetabular rim. So when you try to abduct, instead of this being the axis of abduction, this becomes the axis of abduction. Abduction becomes restricted, and this restriction is lost if you flex the hip. So this is called as a hinged abduction. Later on, 30 to 40 years, that means later means 30 years up to 30 or 40 years, osteoarthritis would develop in this hip. So on X-ray and clinical examination, you should diagnose Perthes disease. If there's limited painful rotation, which is the tamponade stage, then you can see the shrunken nucleus on X-ray, so that which indicates that the growth has become impeded, it is necrosed. Then it becomes fragmented, which means that there is vascular infiltration. And finally, you see ossification around the avascular head, which is the head in head sign. And normally, if there's no weight bearing up to now, the head would regain its normal shape and there will be no loss of shape. However, if there is weight bearing, the first sign is that the lateral pillar, if this is the neck, here is the growth plate, then this part is called the lateral pillar. And if the lateral pillar is lost, then there is increase in the risk of shape loss. So what will happen? The head will become flattened. If this is the acetabulum, it will no longer remain round. It will become flattened, as you can see in that X-ray also. Then you can see the axis shift on the AP view. On the AP view, the head will become posteriorly directed. If this is the acetabulum, this is the trochanter, the head will become posteriorly directed. Then that will be on the lateral view, and on the AP view you will see it being directed downwards, leading to the adduction deformity. Then there is three things that you should look for in an old case of Perthes disease. The first is loss of congruence. Normally the joint space all around the head is equal, but here the joint space is more and here it is less. So this is called as incongruence or loss of congruity. Then the second thing is that if this is the edge of the acetabulum, a part of the head is lying outside the edge of the acetabulum. This is called as loss of containment. And here the rim of the acetabulum will indent this portion which is outside and cause hinged abduction that I have already explained. And this part is called as chylus. If you want to treat chylus, if you want to treat hinged abduction, you will have to remove this chylus, which is called as chelectomy. Then sphericity is lost. The head has become flattened. This is the head, and this should have been the head. This should have been the head. So this flattening you can test by what is called as a Moses circle. You can put these circles like this on the head, and the head should correspond to these lines. So by Moses circle you find out loss of sphericity. So congruence, containment, sphericity. These are the things that you test for. Now during the tamponade stage, bed rest, and you find that the tamponade stage is over if the rotation becomes painless and free. Now, weight relieving brace till the head is soft. So there's a tricycle brace. If this is the umbilicus, so this is the abducted limb on a tricycle brace. And from here you have the weight bearing part of the brace, which bears weight on the ischial tuberosity. So here is the weight bearing part of the brace, and the hip is held in, abduction, internal rotation. And this is the limb on the other side. So this is called as the tricycle brace. If you don't have the facility of the tricycle brace, so the child can still not walk, you can give a hip spica in the contained position when the head is best contained, and that is abduction and internal rotation. This is called as broomstick plaster. So it is abducted and internally rotated. Internally rotated. So that is called as the broomstick plaster. Then you have to take an X-ray and diagnose loss of congruence, containment, and sphericity. Basically, you deal with containment and the deformity. So containment, you remove the callus, so you deal by chelectomy. Chelectomy to treat hinged abduction. Then you do a pelvic osteotomy to improve containment. You can also improve containment by doing a subtrochanteric adduction osteotomy. That will also rotate the head in this direction and improve containment. So a pelvic osteotomy or a femoral osteotomy, but pelvic osteotomy is preferred to femoral osteotomy. It gives better results. Now, what are the various types of Salter's osteotomy? See, this is an example of cherry osteotomy. There's Perthes disease on this side, and you have done an osteotomy from the greater sciatic notch till below the anti-infelic spine, and you have shifted the upper part laterally. So the acetabulum is now better covered. So this improves the containment, and if you remove this extra callus, then it will cause the abduction to become normal. So Chiari is a straight osteotomy where you move the upper part laterally so that the acetabulum becomes better contained. The head becomes better contained now. If this is the head, it will become better contained. The Salter, you angulate, so there's an angle here. And Pemberton is a partial osteotomy where you tilt the roof of the acetabulum downwards. Tilt this roof downwards so that it better contains the head. So this is Salter, Chiari, and Pemberton osteotomy, and this finishes the management of Perthes disease. Rest, traction in tamponade phase, prevent incongruence, loss of sphericity, loss of containment by a tricycle brace or a broomstick plaster. If there is loss of containment, do a Chiari, Salters, or Pemberton osteotomy, or a femoral osteotomy, subtrochanteric femoral varus osteotomy to contain the head. If there is Loss of osteoarthritis, then very, very important at 30-40 years, patient may need total hip replacement if there is osteoarthritis, which is usually very late. Thank you.